All right, and we're recording. Hello.
Hey,
Hi. Would you please go ahead and introduce yourself?
sure. My name is Abeer Al Majali. I'm 30 years old. I'm an infectious disease attending. I'm Jordanian by nationality and mostly grew up there when I was younger. Um, I did also spend a good amount of time in India when we were younger, so grew up both in Jordan and India before I moved to Qatar for pre-med and med school, um, and then to New York to finish off med school with Cornell Qatar, and then moved to Florida for medical residency, St. Louis for infectious disease training, and now I'm in Peoria, Illinois, a rural area in central Illinois, practicing as an infectious disease physician.
Hmm. So, how many years total have you been? How many years of total training? I asked Maze this as well. You went to
Yeah.
school with Dr. Alkawaz, right? My first guest. So,
Yes, I did. So our program was a little different in the sense that our 4 years of pre med were condensed into 2 years of pre med. So we did 2 years of pre medical education, then 4 years of med school. Both me and her did the same thing of taking a year off during med school towards the end. My year off was more to kind of refocus my goals. I kind of med school can be draining, so I got to a point where I just wanted to refocus, make sure I'm doing what I'm doing because I love it and I want to do it, and make sure I'm applying to the right specialty when I ended up applying for residency. So I did take a year off towards the end. So that was an additional 5 years. So that's a total of 7 so far. Then 3 years of internal medicine training, and then 2 years of infectious disease training. And now I'm finally practicing independently as an attending. So this is my first year doing that.
well, congratulations.
Thank you.
Um, this is your first. So you just started like calendar year 2020, or
So in July 2020 was when I started this new job. So it's only been about 6 months so far.
okay? So you came right in the midst of COVID.
Yep. Yeah, I went into infectious disease not knowing that it's going to be, in the spotlight so much. But it was, yeah, it's definitely very different. It gives a whole new meaning to training on the job when it comes to COVID. Obviously, for all healthcare providers, be it doctors, nurses, nurse practitioners, PAs, but especially for us in infectious disease, because a lot of people were turning to us, and for some reason, everyone thought that we might have some information that everyone else doesn't have, and it was all evolving so quickly. And I'm like, we're all pretty much on the same page here. This is a new infection. No one knows anything about it, and we're all learning together. So
Mm.
yeah, it was an interesting place to be at during the end of my fellowship and start of my attending year.
I think that's kind of the point that most people don't get and causes a lot of frustration is that it is a new disease. And
Mm-hmm.
a lot of, when I talk to people just in my free time outside of work, everyone gets so frustrated that people don't understand, well, they said this, so this is how I'm going to live my life. But now they're saying this. And, it's new, so we're just doing the best with what we have, the data we have.
Yeah, and that's the problem. I think, what happened is that's what created so much of the mistrust that we're seeing now from the public when it comes to, the CDC saying, well, now there were these paradigm shifts, especially towards the beginning of the pandemic, where we were talking about no masking at all, and then everyone needs to be masked. And
Mhm.
when we were very fixated about cleaning surfaces as opposed to masking, right? And now we know that that is not as an important mode of transmission as person to person transmission is. So we're more focused on masking as opposed to cleaning surfaces and fomite transmission. So I think all of these paradigm shifts created this mistrust, and I do think there's a shared responsibility there, because I do think that the authorities that were giving these these policies, that were creating these policies, maybe there wasn't as much of an explanation or as much of transparency to for people to understand why they were being made. And so it does explain why someone would, come on, come on, like initially you were telling me I'm forbidden to wear a mask in public. People were being shamed for wearing a mask in public. And then all of a sudden, just a few weeks later or a month later, you're being shamed for not wearing a mask in public. So yeah, it definitely created this, it was part of the polarization that, happened later, and the mistrust that we still see till now.
So what does a normal day look like for you at work?
So a normal day, basically infectious disease is kind of broken up into both outpatient and inpatient practice. So it really depends on whether I have been assigned to an inpatient team versus I'm just doing my regular outpatient stuff. If it's inpatient, then it's just getting obviously a new list of consults that were already on the infectious disease list, and then just receiving new consults throughout the day. It can get pretty busy, infectious disease. So individually you can be carrying anywhere from 10 to 20 patients as an attending physician, and go over the patients, round on them, give recommendations, and it's kind of the same for about a week to 2 weeks while you're on inpatient service. It depends on whether some people will go into private practice purely, some people will have a teaching component. So because I am in a university setting, if I'm on the teaching service, then your rounding will also include having learners. So we'll have residents and medical students round on these patients with them, and kind of teach them about them. There will be some obviously built-in didactics and lectures within the day if you're on teaching service. So that's mostly inpatient in a nutshell. Outpatient is both general ID and HIV care. And that is, that's a lot of, especially the HIV care, there are a lot of social aspects that play into it, and a lot of community outreach that's part of that. And there's obviously also some time that's dedicated to just research, especially now with COVID. There are a lot of ongoing clinical trials that if you're in any university setting, most of our infectious disease attendings are involved in some of these clinical trials. And there are also some community outreach projects that are in play now because we're trying to get ready for mass vaccination, basically as soon as it becomes available for everyone. So the practice of ID is pretty busy. What I would say is that we are thankfully more of and that is kind of in line with my personality, we're more of a thinking specialty than a procedural specialty. So it's very cognitive. It's really about taking a patient and breaking apart the information and trying to put it in a story or in a narrative that makes sense. Rather than being on the go and intubating and placing lines and all of that. So I do like that aspect.
For people who don't understand, can you explain what rounding is? For people
yes. So rounding is basically, you get a list of patients. You may know them or may not know them from before. Typically what we do is that we go over their medical records, which are now electronic everywhere. So you go over the information that you have in the electronic medical record, try to learn as much as you can from there. And then the rounding aspect is actually physically going into the patient room and seeing them and asking them any additional questions, examining them, making sure you're not missing anything, and communicating your plan of care to the patient. That, again, may involve or may not involve learners, depending on where you practice and how you practice. And so if it does involve learners, then there's also bedside rounds where we teach at the bedside the residents how to examine a patient, what each examination finding may mean, try to come up with possibilities as to what's going on with the patient together. That basically is what rounding is.
Have you ever...
sorry, I don't mean to interrupt, but I forgot to include that now most of the time these rounds are multidisciplinary. So It doesn't only involve the immediate, infectious disease team. We run with the nurses. We ask them if there are any updates on the patient. It also includes talking to other subspecialists and the primary team who are taking care of the patient to kind of come up with a joint plan for them.
Mhm. Have you, in your practice, ever run into any rare diseases? There's always, TV healthcare dramas. There's always some rare disease, or Dr. House finds this or that. Have you ever run into anything that just kind of blew your mind, or was very out of the ordinary?
I'm trying to think of the rarest thing I might have seen. That's the thing. I mean, there are a lot of rare diseases that I would see and may be mind blowing to other people. But after a few years of doing infectious disease, maybe they're not as mind blowing to me. But, things that maybe to me and you, we see regularly, but, necrotizing fasciitis, or what is commonly known as flesh eating bacteria, which is, an emergency, a medical emergency. Just it's really impressive just seeing patients hours apart and seeing how aggressive these infections can be and how life-threatening, how quickly they can become life-threatening. And I think what's most impressive is, to me, is now, a huge thing is infectious disease in transplant patients who transplant patients are placed on medications that lower their immunity. As are, our regular HIV patients if they're not on any medication. So their immunities are very weak. And just the kinds of infections you see in these individuals once their immunity is just a little weaker, it's very, stuff like, tuberculosis, stuff like mycobacterial infections, fungal infections are everywhere. It's just interesting to see that as soon as, the immunity lets its guard down a little, all the different infections that you can see. But I'll have to think of a specific interesting story and get back to you about that. I can't think of a specific story.
Okay.
Yeah.
So you talked about when the immunity lets its guard down. Does that kind of, certain communities, they talk about, at least since COVID's been on, about the importance, COVID highlights the importance of just being healthy and just doing things to make sure that your body is ready to fight infection.
Yeah.
Do you have any recommendations? Vitamin D is something that I've talked about a lot because I've seen some of the early research on it. But what can people do just to, protect themselves if they're going to, in the event that they get COVID?
Yeah. I mean, it's kind of crazy. I mean, it's both good and shocking how uninformed we are, even in the medical field, about things that are non-pharmacologic that can actually help you fight off infections or just be healthy in general. I feel like most of our education is based on, once the person gets sick, we do A, B, C, D, but preventative care is just not as well highlighted, I think. And they're working on it. I think medical education is trying to catch up with that, but I don't think that we are where we should be. So things as simple as good nutrition. We do know that poor nutrition, so eating fast food and frozen food and all of that, so unhealthy foods in general, they do create this inflammatory state in our bodies, which also lowers our immunity. And that is such a big problem in first world or developed countries where diet has become highly dependent, especially in the US, I can say. I mean, it was such a difference for me moving to the US and seeing how people eat here as opposed to how we ate back home.
Can you give us
that?
Sorry to interrupt, but just since you mentioned it,
Yeah.
what did you notice? What were some of the differences?
I mean, for me, it was it had to be a special occasion for us to actually, eat out in general, for us to eat anything that's fast food or, that's not been prepared at home, is just, it was really a special occasion. It would have to be, I mean, at least months apart. Moving here, I did and obviously, I mean, throughout college, I did do that too because I I wasn't a good cook. But moving here, I did notice that even kids, you know, like in families, and obviously some people it's not within their control because they're of lower means and it's the cheaper alternative, and that's what they can. That's the only thing that they can get. But canned foods and fast foods and all that, I never saw that as heavily consumed back home as I did see it here. And again, I do appreciate that some people have no alternative or have very few alternatives to that, but that's definitely a big part of it. You know, the way we eat from the time we're kids determines a lot about our immunity and our ability to fight off infections. That and our level of activity, that's a big one too, right? But we live in very sedentary times, but we live in an especially sedentary community or population as opposed to other parts of the world too. And I really did see this shift because initially when I moved to the US, I moved to New York City where they had to walk everywhere. They had to go walk to the subway at least to get places. And then I went down south to Florida and then moved to the Midwest. And obviously, you know, with my migration through the US, I saw people's waistlines get bigger as I did. And, you know, and I also saw their level of activity go down. And it's a pandemic, right? And it's one of the reasons that COVID was so bad in the US, and we talked about this time and time again, is that obesity, we saw that very early on in the pandemic. It was one of the very poor markers or prognostic markers for people with COVID. They would have no other comorbidities, but they're obese and they end up doing very poorly with COVID. So yeah, that was, you know, those are definitely things that people should be aware of. And it's never too late to start. It's never too late to, you know, get off the couch, start working out, start eating better. And those are very simple things. You don't have to go and, you know, buy a multivitamin or buy any vitamins if you can't afford that. Everyone can afford to just, you know, get up and do some sort of activity.
Oh, shoot. I just lost the question I was going to ask you. So, you know, most people in the US started to hear about COVID maybe around January or February. You know, it was in China, and then, you know, we started to hear a lot in India. When did it start to pop up on your radar?
So it was around that, it was around December, right? I mean, late November, early December, but it was around that time that we weren't really sure it was going to result in a pandemic. So we knew there were reports from China that there is a new virus. Maybe the reports weren't as efficient in trying to convey how contagious it was at the time and how prevalent it was back in China. And it did lead to a level of underestimation in the US as to how bad it can get if it did get to us. I think the panic really set in and started when it got to Italy, when it got to Europe. And we saw a country that was being very transparent about what's going on there. And we saw how bad it was. And I think that's when the panic really set in, because up until that point, we were all thinking, yes, it's bad, it's a new infection, but, you know, we've faced this before. We've had other novel infections and viruses that have mutated, especially coronaviruses that have mutated before. We've seen the Middle East respiratory virus, we've seen SARS, and we were able to stop those, so we'll be fine. But I think when it got to Italy and we saw the extent of damage it did there, that's when we were in full-on panic mode here in the US.
Now, why was Italy so harshly impacted so early on?
Some of the their demographic, it's an older country. So they do have a, you know, high number of older individuals. I'm not sure about their numbers when it comes to obesity, but I do know that they have a very big older demographic. And I do think that they were, I mean, if you compare now how badly Italy was impacted to the rest of the world, it doesn't seem out of proportion, right? I do think they were one of the first countries that were very transparent about what's going on there. And that's when we took a step back. But I mean, it definitely, I mean, when you compare numbers in Italy to what's going on in the US. No one is as heavily impacted as the US has been. So yeah, I don't think it was especially bad in Italy compared to the US, but I think it was the first time we realized, oops, this is very serious and it's getting here. Or actually, I should say it's already here, but we were just not as aware, or we weren't testing as well at that time.
So that's an interesting point. I know a lot of people in the beginning, and even still, they say, "Oh, I know I had this in December, or I had some terrible cough and fever in late November."
Yeah.
I think it's been in, like, when do you think it was in the U.S.? I mean, do you think it's realistic that people had it in 2019, like December 2019 in the U.S.?
Yeah, I mean, I think it's realistic to think that they might have, especially that it was around the time of the Chinese New Year, right? And there was a lot of travel back and forth. I think it's not unrealistic to think, but obviously there's this whole thing where people would like to believe that they I think I heard that account so many times back then, is that people wanted to think that they're immune now, right? Like, oh, I did get sick back in December and I think I'll be fine. And I do, don't forget that November is around the time where we have all the other respiratory illnesses, all the other viruses. That's when they emerge, fall, winter time. So they could have had something else, but it might have been. They could have had COVID-19 back at the time.
Mm-hmm.
Yeah.
You mentioned being immune after infection, so I did want to talk about that.
Yeah.
What do we know about how many people are being reinfected with COVID-19?
So far, that's a really good question, because so far we know that it's rare. We know that it does happen. Sorry, I should start with, we know it does happen. Mm-hmm. We know it's rare. We know that the good majority of people will have natural immunity for anywhere, they're hypothesizing, from 3 to 6 months following infection. But we know that it's happening now. But there is another layer of complexity that's been added to that now we have all of these mutants that have been identified, right? And some of them we think are escaping natural immunity, meaning that they're different enough that the immunity that someone developed to COVID-19 during their first infection might not be efficient in protecting them from a second infection. Mm-hmm. Now, whether it will give them maybe a milder infection is a hope that we have. But we do know that at least there's now a South African mutant that we think escapes immunity from the original COVID-19 infection. So I think it's more complicated than just, is it just the one virus and can we get reinfected with it? Because now there's all these mutants that could reinfect people. But if we're talking about the exact same virus, it's rare to get reinfected with it, but it can happen. But we have seen that when it does happen, that maybe it is milder than it was the first time.
Yeah. So for people who have been infected, I imagine they've done studies to, look at the blood and see, how long they have antibodies.
Yeah. So, so far that's where those numbers come from. The 3 to 6 months, they come from studies in the lab. But at all times, we know that studies in the lab have to translate into real life before we fully rely on that information. So basically, we have that data telling us that immunity can last from 3 to 6 months, but clinically, we have to watch and see as time passes by people who have been infected once and how they may or may not get reinfected again. So I think we're still waiting on more clinical data to be able to clearly say, yes, once you've had it, then you are protected for a year after or a couple of years after. But we still don't have that, just because, we're still, we're a year out pretty much. So we're still waiting on all of that data to come out.
Kind of the biggest thing in the news recently has been the variant they're talking about in the UK, which may be the South African variant that's, 70 to 80% more contagious, but they still think that the vaccine will cover that.
Yeah.
So is it similar enough? It has the same protein that it codes for?
So the UK virus, I want to say so far only Pfizer confirmed that that the vaccine still protects against it. The others, there has not been confirmation yet, and they do think that at least the South African mutant will escape that immunity. Now, that being said, people should realize that the initial efficacy that we were told about with the COVID vaccine, which is about 95%, right, is extremely high. And it's higher than what we've seen with many other vaccines. Now, if you get vaccinated against COVID-19 and you go out and let's say the South African mutant starts circulating in the community here in the US, somehow, someone travels here and it starts circulating here. And let's say the level of protection that you have at this point goes down from 95% to, let's say, 70%, because now there is a certain percentage of that mutant in the community. That is still good immunity. That is still higher than, let's say, the flu vaccine that we still preach about each and every year. When its efficacy is between 40 to 60%, we still tell people every year, you have to get your flu shot. So even if it does reduce the efficacy a little when there are other mutants, while we're waiting for new vaccines to keep getting developed every year, that should not stop people from getting the vaccine. It just says that maybe instead of the 95% efficacy, we're going to go down to a little bit of a lower efficacy, but we'll catch up. Now that the technology is available, the mRNA technology is available, it was developed very quickly. If they have to make some adjustments to, make next year's vaccine also include the South African mutant and some other mutants, then that's what they have to do. But it's doable, basically.
The speed at which it was developed is something that frightens people. And honestly, I was nervous about it too. I'm actually scheduled to receive my second dose. Today's Thursday, so it'll be Monday. I'm scheduled to receive my second dose. And I'll be honest, I was very nervous going in for my first dose because, I am skeptical. And I'm not distrusting, but I don't have just immediate trust in everything I hear or see on the news, and I think that's a good thing. But supposedly it's mRNA technology's been in development for a while, like longer than just COVID's been around, at least, right?
So first of all, I have to agree with you, Flay. I've been on the phone with so many patients over the last few days, and the number one thing they ask me is, well, they called it Operation Warp Speed. So, were they really taking all the necessary steps? I do think it's a very unsuccessful name, the Warp Speed thing, because it gave people the impression that we're skipping steps, that we're skipping on the science, and that's how we got to the vaccine, which is not true. As you said, the mRNA technology has been around for a while now, and it was being tested for viruses like the Zika virus. But it's important to be transparent and tell people it was never actually, given in such numbers, or it was never actually given to the public like it is being done now. So this is the first time we're actually implementing it and giving it out in such big numbers. But the technology itself has been studied and has been known for years now. And even if you look at the individual studies that were done for these vaccines, no steps were skipped at all. So they went through all the necessary phases that any vaccine development study has to go through. They tested for all the necessary things in terms of safety and efficacy. So when you look at it, the only question that I hear from people, and that I say I don't know, is questions about, and maybe that's the same question that you had, long-term safety. Because if you tested something over the span of 2 months, and now let's say it's been 3 months out, you can't tell people, I know that a year from now or 2 years from now, I absolutely know what the safety profile is. But here's what you can tell people. We know we've been using vaccines for a very long time now, and we know that the side effects of vaccines occur within days to weeks, mostly 8 weeks out, from 6 to 8 weeks out from the vaccine. So we know that that's the safety period that you need to have data on, and we have data on it. There has been no, long-term effects that we have been worried about with other vaccines. So, I don't see the reason why we should be worried about any long-term safety concerns with these vaccines. But obviously, that's why there's also the safety portal that the CDC has, so that people are supposed to report any side effects that they have when they get the vaccine. I think that's a very important step that everyone should be told. If you're getting the vaccine, download the app or go on the CDC website and report any side effect that you have. Because in terms of serious side effects, we don't usually see those past that 6 to 8 week mark. So people should be reassured of that fact, but they should also be told that no steps were skipped. They had to go through all the necessary steps. Now, for instance, look at the Russian vaccine. They did skip a step before they went on the market. They weren't done with their phase 3 studies, so they're finishing them up now. But the 2 vaccines that are available in the U.S. now, Moderna and Pfizer, they had to go through all the necessary steps, and none were skipped at all.
Mm-hmm. Which if you don't mind sharing, which vaccine did you receive? Are you vaccinated?
Yes, I got both. I got both shots. I got the Pfizer vaccine. It was the only one available at the time when they started giving them out at the beginning, because it was approved before Moderna here. I was one of the lucky people. I didn't really have any side effects. I got some soreness, basically, just where I got the injection, and even with the second dose. And for transparency reasons, there are reported side effects, especially with the second dose. People developed fevers, myalgias, headaches, just fatigue. But those are supposed to last.
Most people don't know what myalgia is.
Muscle aches and just kind of feeling crappy overall. But those are supposed to last for about 24 to 48 hours. And they responded very well to Tylenol most of the time for people who did have them. And the reason, when you do have these side effects, if you do have them, that's just your immunity telling you that, yes, I developed a response. Yes, the vaccine worked. So for me, honestly, when I didn't have any sort of side effect, I was a little disappointed, although I know it's irrational, but I was like, I wanted that confirmation that, my immunity did mount a response to this vaccine. It's uncomfortable, and, no one wants to have a crappy 24 to 48 hours, but I think look at it from a big picture kind of thing, and just wanting the possibility of us just going back to a normal life again, I think is worth it.
That's one of the reasons I decided to go ahead with it is I'm just tired of being cooped up and not being able to do everything I want to do. Also, a lot of my coworkers are, seeing a fair amount of COVID in the hospital right now, and it's, making a way around the coworkers. So
yeah,
I'm getting Moderna, and I based off what my coworkers are going through, I definitely expect to have a reaction. So just gonna sit around and watch TV and movies for a couple of days, I guess. But
and just time it well, like right before a day off or something. That's what I did, because I was expecting that I'm gonna have some sort of reaction. I timed it before a day off, but it turned out to be unnecessary. But a lot of people I know did have some sort of reaction to it.
Yeah. So you said you started to hear about COVID in December. And when did your organization start to prepare for it? And what preparations did you make?
That is a good question. It's a time that I look back on, and just it was not a pleasant time overall, mainly because I think the mixed messages that were being given out to the public were, yes, they were disconcerting and they were scary, but I think anyone who was a healthcare worker at the time knows how scary it was for us in the hospital, because the institution that I was at the time didn't seem to have prepared well for it, again, because of how just quickly we got the information, and all of a sudden we said, oops, we're probably in the middle of a pandemic. And there was this hoarding of personal protective equipment, and sometimes out in the community, and sometimes by some hospital systems. And I guess ours wasn't as well prepared. And then they start rationing masks. And I think at the very beginning, we had nurses chasing us down because they were told to, asking us to take off our masks because we're not supposed to be wearing masks out in the hallway. And I think initially the assumption that we were working under is that there's no community spread. And I think that at the time it made sense, if it's only in the hospital and it's only certain people and they're going to be under some sort of isolation, then it's fine with me. And so at the beginning, I was fine with that. But then when we started seeing cases out in the community everywhere, and we were working in the hospital where these people were coming in, and then there was an issue with testing too, if you remember, and there weren't enough tests out there. So not everyone was getting tested, and there was rationing of tests too. We're like, so you're telling us that you're not going to be testing everyone. They're going to be coming in with this new disease that we don't know all the symptoms of. And we're not allowed to wear masks unless they're a confirmed COVID case. And we started seeing all these healthcare providers in other countries die of this disease because that just the amount of virus that they were being exposed to, even though they're young and healthy, was more lethal than what you would be exposed to out in the community. And so there was this just fear and panic in the hospital, I think. And I tried to be, I'm kind of a calmer person. So I tried to, stay calm and not panic. But, at the back of your head, you're like, does anyone really care about us, being in this situation? And it wasn't till honestly, a month or two later till the initial surge kind of eased up that we started getting more personal protective equipment and the testing ramped up and things got a little better. And obviously we also got desensitized to it because it was everywhere and it was there all the time. But it was a very scary time. I think the country and most institutions were not well prepared for it. And we had ample time to prepare, I think. We heard about it in December, and this full-on panic mode that I'm talking about was in, I think, February, March. So there were at least a couple of months to prepare, and that was not done appropriately. And I think it wasn't done appropriately higher up, and then it kind of trickled down to all these institutions that also weren't well prepared. And I think healthcare workers and obviously the patients were the ones to suffer when that happened.
Mm-hmm. You said something about healthcare workers who were young and healthy being exposed to larger amounts of virus, so higher viral loads. Can you talk about that in terms of, I don't know, I get how that affects the rate of infection, because I really don't understand that either. Like, what's the difference between the infection of a small viral load or a large viral load?
Yeah. Well, I mean, we started seeing these doctors who or nurses who were younger and were generally healthy as far as we know, because obviously, as you know, sometimes people may have an underlying immune disorder that they're unaware of. But as far as we knew, these people were generally healthy. And when they were exposed in the hospital, they were getting much sicker than they were if they were exposed out in the community. And the theory that was proposed behind that is that it's just the amount of virus that you're getting exposed to when you are in a healthcare setting. I mean, think of, and my prototypical example for that, I mean, think of a nurse. They're at the bedside for a very long time, and there's this continuous exposure. And on top of that, there are all of these procedures that are being done that what we call aerosolizing procedures that basically create these tiny particles that will get through just a regular surgical mask, and they're getting exposed repeatedly. And so the theory was that this repeated exposure at higher amounts of virus was making people sicker. But when you're out in the community, you're walking by someone or you're talking to someone, even if you're sitting at a table together, maybe they cough, maybe they touch something, just the amount of virus that you're getting exposed to and the quality of the particles that the virus is enveloped in, they're bigger and they're harder to, get into your respiratory tract and cause infection. And so people weren't getting as sick out in the community as they were in the hospitals. And again, this is pre the phase of proper personal protective equipment, because once we figured that out and once we had enough supply of personal protective equipment and didn't have to, keep reusing the same mask for 2 weeks, that's when things got a little bigger. And that is literally what was happening in my fellowship. We were we were being told to get one mask at the beginning of the week. And I'm talking just about a regular surgical mask. I'm not talking about an N95, which is, the finer filtration one. And we were asked to use it for a full week. And it was ridiculous because I'm in constant contact with patients, and I mean, you're reusing the same mask. You're sometimes coughing in it. You're sneezing in it. You have it on for a full shift while you're at the hospital, and then you're reusing it day in and day out. So it's just, yeah, it was not great. It was not a good time for sure.
Do you still do they have you reuse your N95s? Curious.
So yeah, N95s we still reuse. We don't use that same N95, obviously, for going into a COVID positive room as opposed to a COVID negative room. But yeah, I still, pick up an N95, but at least this, now it's left up to my judgment. If I feel my N95 is no longer good for use, I'll just toss it and ask for a new one. They are There is a better supply now. So if you do that, you'll always have an N95, but that was not the case at the beginning. I'm not sure if your experience was similar in terms of mask reusing at the beginning.
Yeah, we were reusing masks quite a bit. We still reuse our N95s. I don't know if there's actually. I don't know. I don't wear an N95. They actually don't fit me very well. I also decided to stop shaving right at the beginning of the pandemic. I shaved. It didn't work out well for me. It's not a good look. So I was using a papper for a while.
Got it.
Now I have a very nice respirator, the Dreger. I don't know if you're familiar with it. So it has the two filters, and it's
oh yeah. The alien mask, yeah.
Yeah. My unit is not designated for COVID patients. That doesn't mean that we don't get patients who are possibly COVID positive, and we have had some patients convert to positive recently. But I typically just wear the surgical mask, which we were reusing a little bit in the beginning. There was, like you said, a hoarding, and so we would find some boxes and stock up.
Yeah.
Or if we were drawing sterile cultures, if we were drawing blood cultures from a patient, that comes with 2 masks. So we'd pocket those masks just to make sure that we had some.
Yeah. Yeah, and that, I mean, I don't know if we were going to talk about this at all, but that kind of, I mean, my big thing about why I went into ID, why I love ID, why I like what I do is healthcare inequities. And it's ridiculous when you look at certain hospitals in certain parts of the US where that was never an issue, depending on how well funded the hospital is and who it treats and what patient population goes there, as opposed to other parts of the country where inner city hospitals and all of that, where that was such a big issue. Because I mean, don't only think of the healthcare workers there, but think that as healthcare workers, if we weren't properly protected, we were also exposing our patients to the virus too. And it's another thing where, where you live and where you come from is such a big determinant of how you just are generally going to do. And it's frustrating, especially for, a country like the US, where that shouldn't be as much of an issue.
Yeah, we do spend more than most other countries, right?
Yep.
I mean, I don't know too much about the funding of hospitals. Do you? What does Medicare, was the federal government paying out for PPE? I know that was kind of talked about on the news, but I don't know if anyone made anything definitive.
Well, I know that whatever was being, at least at the beginning, whatever was being funded or being provided by the government was just not enough. And so some hospitals did their own thing. I know that some hospitals in New York, flew out and got supplies from China, where the pandemic wasn't as bad at the time. And so every hospital and kind of every state and maybe every county had to be creative and do their own thing and get their own supply. And I think in a time like a pandemic, you need some sort of more centralized instruction and supply, because, a US citizen or a US resident is a US resident everywhere. And it shouldn't be that just because you go to a hospital or the administration has more money or more connections or more ties and can get more PPE, then you're going to do better than where that other unfortunate patient is going to a hospital that doesn't have the same resources, and you're going to do worse just because of that. But yeah, unfortunately, that was, the reality of the matter at the time.
Yeah, it is. It's very sad. And I think about that, especially in the ICU setting, everyone's already so sick. We see, I get what you would call more typical diseases, hospital-acquired diseases, C. diff or pneumonia. But to think that now you could get COVID, it's sad. It's sad. It would be sad that if that is what caused you to lose your life.
Yeah. Especially the preventability of a lot of these infections. Again, that's why this is such a big part of infectious disease, is that a lot of infections do predominantly affect the the less affluent and the less fortunate, or the less financially endowed, because a lot of these infections are preventable either through testing or through normal and good living conditions, hygienic living conditions. And the fact that we're still that in 2021 we're still living at a place where a simple HIV test could have saved a young life, but it was just not done the way that it should have been done. Or, I still see patients who come in with illnesses because there are body lice where they live, and it's just because of the poor hygiene of where they live, and they end up with a life-threatening infection just because of that. It really screams of living conditions in a refugee camp. Like, there are some patients that I see, and I cannot believe that I am practicing in a country that, as you said, has the most expensive or the highest healthcare expenditure in the world, because these are infections that we're not supposed to be seeing if you had your basic needs met as an individual, speaking of hygiene and just a good normal diet and that kind of stuff, and clean water, clean food. And the fact that those needs are not being met, such basic needs, is just, it's really horrifying at given the time and the country we live in.
So what can we do for the community to help with that? I mean, a lot of people would say, well, I mean, how much of that is lifestyle choice versus what's forced upon people? And I don't mean to sound callous when I say that.
Yeah.
I'm really curious. But, what can
I
we
think, do? Yeah. I mean, and we saw this a lot, right? Even with COVID, where the worse outcomes were seen in Black Americans and Latinx communities, also with COVID-19. And I mean, there's a reason behind that. The reason being, it's not there. I don't think there's one right answer as to why that is the case, be it with this or with other infections. I think that there are modifiable factors that we can help with, and there are maybe more personal factors, like you said, that I can't force someone to live a certain way. But the modifiable factors that we can help is, number one, access to healthcare. I mean, as I said, practice in a little bit of a more rural setting, I would say, although I live in a city. But a lot of the patients who I see live out in rural communities, and they travel to come see an infectious disease or a primary care physician, and they just don't have access to healthcare like people in a city would. And because of that, a lot of basic things like just routine testing for HIV or just simple education, educating the patient about certain things that could be detected earlier, vaccinations, all of these things are missed on because of access to healthcare. So that is one problem that we can do something about, right? Other than that, it's also there is definitely a huge gap, and there is mistrust and from some of these communities towards the healthcare community, towards doctors, and that comes from a very dark history in medicine, right? I mean, think about the Tuskegee trials where
Yeah.
Black Americans were not told that there is a treatment for an infection that they have, which was syphilis at the time, just because we wanted to observe them and see what the natural course of the infection is when there was a very obvious treatment. So this mistrust is not coming from a vacuum. There's an actual reason for it. And I think obviously representation matters. So having healthcare providers who look like the patient, who can talk to the patient in a way that they can relate to is a big thing. And being able to answer these questions for our patients, and some of these things might be bigger than you and me, which is how accessible is medical education or even nursing education to some of these people who might be better able to communicate with these underserved populations, right? I mean, it's a privilege to be able to go to med school and be where I am right now. And medical education in the US is extremely expensive. And who are the people who are able to get this education or be able to go to nursing school and be better able to communicate with these patients like they should be able to, So some of these things are, yes, they're bigger than us, but I think the little things are just being, being more understanding of where people come from when it comes to be mistrust of the medical community and healthcare personnel in general, and being more patient for sure.
Yeah. One thing I was thinking about recently is I've had people in my family who have asked me, should I get the vaccine? And I try to explain to them my level of understanding, which is not spectacular, but I try to explain, mRNA technology has been in development and just utilizing resources that I've seen. And I've noticed that some people, when you try to explain something to them, they act as if they already understood that and you don't need to explain it to them. And one of the healthcare providers I work with just the other day was explaining that some people may feel ashamed that they already don't have that level of understanding that I, as a registered nurse, have, or you, as a physician, have.
Yeah. And I've even seen that from other physicians, like I've seen some physicians have some questions about this new technology. I mean, and they feel shamed by other healthcare providers and doctors that, obviously you're going to have to get the vaccine, you're a doctor, but they have these questions and they're a little ashamed to ask them because, am I going to look less competent? Should I already know this information? And I think that, one of the ways we were thinking about, because we do have a vaccine hesitancy committee, we were thinking about creating this hotline where it's confidential for any healthcare worker to call and say, well, my specific complaint is, or my specific question is this, and can you explain it to me in a way that, would put my questions to rest? Because I think every question is valid, right? I mean, and everyone's background is to be respected, whatever it is. So if we're able to answer those questions, most of the time they're very simple answers. It's just, creating that space where people feel safe to come and ask these questions.
Yeah. Sometimes there is an error that it's wrong to ask a question. Even working on a neuro ICU for the last 2.5 years, I still have very, very simple questions. And I'm almost embarrassed to ask, especially when there are new nurses around, because some of the more experienced nurses will look at me like, well, you should have already known that. And it's almost like they want me to be ashamed that I don't know this, but it's hard to learn it all. And it's hard to develop a deep level of understanding that quickly. And I just maybe need to hear it from the way you explain it.
Yeah, no, I fully agree. And I think that's really unfortunate, because I feel like we kind of teach that also to our learners. I mean, probably nursing students and medical students and residents, we kind of teach them to be scared to ask questions because you're going to look dumb, or you're going to look like you don't know what you're doing. And it's scary because I'd rather the question get asked to be, before it becomes an actual issue, and someone doesn't know what they're doing. But yeah, it's definitely something that I don't like about the medical culture overall, is that there is this there's this malignancy that's kind of built into being in the medical field, unfortunately.
Yeah, I think it's an ego thing.
Yep.
You mentioned HIV a few times. What, what's your
Sorry.
experience when you did that to a racetrack?
No, motorcycle.
Oh, wow.
Yeah.
What's your experience? I mean, what work have you done with HIV?
Like,
In terms of like in the community and everything.
so basically, I mean, it's part of our infectious disease training to work with HIV patients. HIV, as you know, was also one of the it was one of those terrible pandemics that the U.S. and the world went through. It's and it also, like many other infections, had a lot of social implications, and to this day it still affects a lot of people on more than just a medical level, right? I still see patients who are scared of the stigma that comes with being HIV positive, especially the ones who live in more rural communities who are still more conservative and are they don't want to come out. They don't want people to know that they're gay, or uh, they don't want to be perceived a certain way. They don't want to be perceived as promiscuous either. And so but HIV has come a very, very long way since then, at least medically. I mean, also socially, but at least medically. I mean, now HIV is, fortunately, it's better than a lot of other chronic diseases. If you have high blood pressure or diabetes, you have this lifelong disease most of the time, and you have to keep getting readjustments in your medications. But with HIV, if you just take that one pill a day and continue to be on it, it should not really affect your lifespan. It should not affect your life in any other way. You have a pretty much normal immunity after you're well controlled. It's just remembering to take that one pill a day. For some people, it's more than one pill, unfortunately, if they've developed resistance in their virus. But it's amazing what just adherence to this medication can do. So we have come a very long way. I think with HIV patients, it's very gratifying taking care of them, because a lot of our HIV patients come from underserved populations. They come from marginalized populations, and just seeing them just get over not just the implications of being infected with it, but the trauma that came with the diagnosis. A lot of my patients, were, when I worked at an inner city hospital, I mean, the way that they got HIV is that they were being sexually assaulted by a family member, or so just being able to tell those stories and get over that initial trauma and kind of make something of their life after that initial phase. It's very fulfilling. So I do mostly clinical work with HIV, where I see these patients in my clinic. Yeah, that's really mostly it. Sometimes we see them in the hospital if their infection is not well controlled, and they come in with other infections or consequences of not taking their HIV meds. But yeah.
And you can really reduce the likelihood of transmission too, as well, right? That has to do with viral load, like we talked about with COVID.
Yeah, so that's a big one. I mean, with HIV, there was a campaign that started not too long ago, and it says undetectable equals untransmissible. So for HIV patients, we check their viral load every few months, and as long as this viral load is undetectable, as in we can't really detect it anywhere in appreciable quantities in the body, they're not able to pass it on to their sexual partners. So that's also a big move towards just removing that stigma, right, and allowing people to lead normal lives. And this campaign was maybe a little successful in doing that and reducing the fear. I still have patients to this day who I see who are in their 60s and say, well, ever since I got diagnosed with HIV, especially women, they say, I've been unsuccessful in finding a partner who would accept the fact that I'm HIV positive. I try to explain that my viral load is undetectable. I've been on my medication for decades now. I'm fine, but it's just hard to find someone who's not scared of the implications of, dating someone who's HIV positive. And unfortunately, yeah, that's a shortcoming on. I don't know who it is. I think we should probably have campaigns like that, and just try and educate people about the fact that if your partner is undetectable, they cannot really transmit the virus to you. So, but yeah, even within the healthcare community, sometimes I do see that not everyone is as comfortable with HIV and HIV treatment, and being able to tell patients, yeah, you're fine now that you're undetectable, you're fine. So yeah, we should definitely be working on that, because it does affect a patient's life way beyond just medically.
Now, how does that convert to actual AIDS? What, I'm not very well educated on this, obviously. So.
Yeah, so I mean, HIV basically, it's at the beginning of the infection, the virus gets into the body, it starts dividing very quickly or reproducing very quickly in the body. And it usually will stay what we call silent, basically. And that's what used to happen in the very beginning of the pandemic. People would not get tested because they had very maybe non-specific symptoms like the flu. And then they were fine for 9 to 10 years. And that's when they get sick. And during that time period, not only is the virus reproducing, but what it's doing is that it's killing off cells, what we call CD4 cells, but they're basically T cells that are part of our immunity, so they fight off infections. And the virus is systematically killing off all of these cells and deactivating them. The transition from HIV to AIDS is just about the number of cells that have been killed off. Once that CD4 count or that T cell count is below 200, that's when we say someone has AIDS. And the reason that distinction is important is that they become at way higher risk of infections that the person with a normal immunity would not be at risk of. So these are pathogens or microorganisms that usually would not cause an infection in someone who has a normal immunity. But once the person has passed on to AIDS, they become at risk for all of these microorganisms causing infections. And that's why that distinction is important for us.
What does treatment look like when someone converts to AIDS?
So it's pretty much the same. We will start them on antiretrovirals, and they may have to go on courses of antibiotics to prevent other infections from happening, the ones that I told you they're more at risk of. But we will continue to follow their counts. And hopefully, if they do have recovery of their counts with treatment, then we can take them off the additional antibiotics, and then they'll just continue to be on antiretrovirals for life. The only thing that's, that might complicate this is if they present with AIDS, they might come in with a life-threatening infection. So, or other diseases. So AIDS can cause some autoimmune conditions. It can cause some cancers. I just had a patient pass. I mean, he was only 34 years old and he was unaware of his HIV diagnosis, came in with AIDS and had a lymphoma, and then died of the lymphoma while still in the hospital. So once that immediate problem is treated, then they just go on antiretrovirals like everyone else, and then they can get to that undetectable level again and just do fine. Mostly.
So you had mentioned access to testing. Who should get tested for AIDS or HIV? I'm sorry.
HIV. So basically, anyone who is sexually active should get tested at least once, and then there are more higher risk populations that we recommend get tested more frequently. So it's usually men who have sex with men, IV drug users. Men or women who exchange sex for money, and known exposures. Obviously, if someone had sex with someone and then they were told later that person was HIV positive, they should get tested too. But everyone else should get tested routinely too, not as frequently, but everyone should have at least, one HIV test if they're sexually active. And obviously, I forgot to mention people who are victims of sexual trauma or rape. They should also get tested for HIV and other sexually transmitted diseases.
Why is it that homosexuals are more at risk?
So it's just the specific sexual practices, really. It's a matter of when with it, it can get obviously transmitted through heterosexual sexual practices too,
Hmm.
but the specific homosexual practices, including anal sex, are the highest risk for transmitting HIV, and
Oh,
that's really the main reason that they should get tested more frequently than other individuals.
mm. Okay. I've just always
Yeah,
been, I mean, always been curious about that.
yeah.
Uh, so I kind of want to shift gears back
Hmm.
to respiratory diseases now. So, I guess we all have friends who are skeptics about COVID and the response to COVID. And one thing that a good friend of mine who is relatively well thought out, he's been asking me a lot about why are flu cases so down this year? Like why has there been such a reduction in flu cases? And I explain it probably because people aren't going to school, they're wearing masks, they're social distancing. But can you expand on that?
Yeah, no, I totally agree with you. I mean, we're doing all the things that reduce the rate of respiratory illness. We are wearing masks, we are cleaning surfaces, we are not gathering in large numbers. And I mean, on top of that, I do think that we have done a good job at vaccinating more people for influenza this year, just because we were so concerned about the spike being a joint COVID and influenza spike when it did happen. So all of those probably contributed to that. And also, I would say, think of the fact that most people, when they get sick now, they're going and getting tested for COVID. In any other year, when people get sick, they would go and get tested for the flu. So we were picking up more people. But now people get sick and they just go and get tested for COVID a lot of the time rather than a full respiratory viral panel. And then if they're COVID negative, they're like, okay, I'm fine, and they don't get tested for other things. So I wonder if we're under testing maybe a little for the flu this year, because we are so fixated on just picking up every COVID case that we can, just for tracing purposes and all of that.
Mhm.
So yeah, I think that's the reason. I've heard that too from some people. I don't understand what the conspiracy rationale is there. Is the thought that, that we're calling flu COVID this year? I mean,
Well, I think, there is a belief that COVID cases are exaggerated and that it's done because I've had a lot of people say, oh, well, hospitals get more money per COVID patient, which may be the truth. I don't know. But, if you can say someone, oh, he has symptoms of a respiratory illness and oh, he's COVID positive, now we get that extra money. We can treat him like that. We can also, a lot of people think that the media is there to scare them, and I don't necessarily disagree with that. I mean, that's how they keep their viewers, but
yeah. I
if we
mean,
can,
yeah. And I do think so. I mean, first of all, I really don't know where that, the fact that hospitals make more money of COVID. I mean, I'm not a big fan of how hospitals make money. Don't get me wrong. I'm not like here to defend hospitals and how they make money and how much they charge people for healthcare. It's absolutely ridiculous. But I don't know if that's based on any fact, the fact that a hospital will charge more if you're COVID positive. I mean, if you're sick and admitted and getting certain procedures done and all that, you're going to get charged either way.
yeah.
So I don't think that has any basis in reality. I do think that, the media and social media and all of that, it was kind of leaning towards either or. It was either full on panic, which in my opinion is never warranted. I mean,
Mhm.
you need to have a plan. You need to warn people, you need to have a plan, but full on panic is counterproductive. And the other alternative was, oh, it's all a conspiracy. We shouldn't do anything about it, which is also counterproductive too. But yeah, I can see where people just mistrust media, because I also think that even towards the beginning, that the hype around it and the panic was just, it was so overdone that if I wasn't an infectious disease doctor, I wanted to turn off the TV and just never hear anything about COVID again.
Yeah.
It was too much. And I think that any person could have gotten overwhelmed with what was being said and the way that it was being said too. So I kind of get where that comes from. But yeah, I don't think hospitals make more money just because someone has COVID. That's silly.
I don't know.
Yeah.
But I'm glad we started to talk about the response. How do you feel the US did overall in terms of its response to COVID, specifically with lockdowns? Are they effective? What does data show?
So, I mean, we know that social distancing and masking are what really made a difference in our numbers. The initial surge only came down because of social distancing and masking. I think the lockdowns were or became necessary because we got to a point where people were not social distancing and masking, no matter how much they were being asked to do so.
Mhm.
And it was a stepwise thing. And yes, it had an effect on small businesses and the economy, but here's where I find it hard to understand where the anti-lockdown mentality comes from, because what caused the economic decline and affected small businesses is the fact that there is a pandemic going on. I mean, that's what really affected the economy.
Mm.
The response itself was deemed necessary because people were not doing what they needed to do. I do think that school shutdowns were probably exaggerated, because we do have studies that show that transmission in schools and overall kids are not high risk for developing severe disease, and transmission was low in school environments if they were obviously modified in certain ways. I think they did certain things. They modified how the classroom looks, how much they're distancing the students' desks. They were all facing in one direction, not facing each other. So there were certain modifications that were being done, and those were effective in reducing transmission, and that worked out fine. But overall, lockdowns only became necessary because people weren't listening. So I do think that the U.S. response was slow at the beginning, but what I'm talking about as being slow is not that, we needed to lock down earlier. I think we needed to develop adequate testing earlier and have adequate personal protective equipment earlier. Start teaching people that they should social distance and wear masks earlier. But other than that, I don't have any strong opinions about lockdowns, but I think they became a necessary evil because people were not doing what they were supposed to be doing, given the pandemic situation.
Have they been shown to be effective? One thing that people really point to is California and how they have some very strict rules in place, but they're also surging at the moment, or
Yeah.
in the last few weeks.
Well, I mean, California itself, I mean, I don't know specifically because they've had a few stricter lockdowns, and then they would ease up a little, and then they would lock down and ease up a little again. But I think, again, what was really shown effective with data is the social distancing and masking. Now, completely locking down and shutting down, that I don't know if there's actual data about that at all. But I do know that there is good data about social distancing and masking. And I think what was happening, and this is all anecdotal and I don't have data for you, but what was happening is that even in California and Los Angeles, I mean, I have friends who live there, and they were saying that, again, there was pandemic fatigue. People were sick of it. So they weren't doing what they were supposed to be doing anymore. So even if the whole city is locked down and you're still gathering in large parties in someone's house and not masking and not doing what you're not supposed to be doing, you're still going to be transmitting the infection. So I think there was definitely pandemic fatigue in most parts of the country. And add to that the fact that COVID seems to be seasonal, just like the flu, right? So this was COVID season. So add to it the fact that behavior was not being, it was not as strict as it should be, and the fact that it was COVID season. But yeah, I see where people are coming from, the stricter places didn't do particularly well, but I do think it's because people were focused on what the focus was being on, let's shut down businesses, when it should have been, hey, it's not really about completely shutting down a place. It's about really having people social distance and mask up. It was really about that, and staying home if they're sick, because it was still a matter of, I just have a runny nose, I don't think it's COVID. And people were still going out and interacting with each other. So yeah, I think it's more about that, and that's where the data is rather than the full-on lockdown uh, that I'm losing the word, but full-on lockdowns.
Yeah.
Yeah, I think that's not where. I don't know if I saw any good data for that.
Mhm. Do you look at data from other countries? Sweden was in the news quite a bit in terms of
Yeah.
they were just kind of letting people, if you want to stay home, you better stay home. But otherwise, we're kind of just going to be pretty relaxed about it.
Yeah.
Can you kind of compare other countries' responses around the world?
Yeah, I've looked at a few, not as in depth, and I know that Sweden did horribly with their herd immunity policy.
Mhm.
Um, I know that some places in Europe did well for a little bit when they were locking down, but again, I think pandemic fatigue just seeped in everywhere. People were just done with not being able to go out and do things and interact with other people. And that's part of the the fascination with viruses. They're so smart, right? They use our own social behavior and our weaknesses to reproduce and spread. And so looking at other countries, I don't know if I see other responses that I think were much better. I do have to say, though, the countries that started contact tracing and testing earlier did generally better,
Mhm.
including South Korea was one of them. Now, did they surge again later? They did, but their total numbers were nowhere as bad because they started contact tracing way earlier on. And I think Taiwan was another one that did pretty well because of that, despite their proximity to China. But I think that's what we were missing rather than stricter lockdowns. We're missing that contact tracing and early testing and early isolation of people.
Hmm. My in-laws are in Australia right now.
Mm-hmm.
Uh, uh, they're living there for just a little bit, but they said it's when they got there, they had to test and quarantine and then test again, and then they said life is very near normal. No large groups, but not everyone wears masks. Everybody social distances, but they're apparently very strict. So I guess each state, you can't really travel freely between the states that easily.
Mm.
And they sounds like they're doing very well. They have very few cases, it sounds like.
I mean, that in New Zealand, they did extremely well. And I think the fact that, their geographic isolation kind of in a way worked in their favor for sure. But yeah, again, they had really good testing, quarantining, and contact tracing. And that's really where it's at. And that was much more challenging with a country like the US because of some deficiencies in our testing and early contact tracing. But also, you're thinking of a very big country, and you're also thinking of a population that's not as amenable to being forced to do anything, right? Um, and yeah, that's all played into it for sure.
So if you could, going with the knowledge you had, if you could go back
Yeah.
to January, let's say, and you were in charge of the
Mm.
U.S., let's just say in charge of the U.S., what would you do? Like what would you do starting January 1st, 2020? You're the boss. How would you run the U.S.?
Oh my God, that's a really big question. So I think that as soon as we had heard of the first case, there were tests that were available from other countries. That would have been the first step, is that I would have made sure that that's a priority to develop the test ASAP and to remove any kind of barriers in doing that, in developing the test, and just administering it way more widely than it was. So especially with healthcare workers, I think universal testing would have not been a bad idea. And contact tracing. So just, that comes with the testing, is that as soon as someone tests positive, is that they should quarantine, isolate. And I would have been way more aggressive with healthcare workers. And I think that's a big problem that we're facing now. And I don't know if you're seeing that too, but we're seeing a lot of transmission from healthcare workers to patients. And that's how it's spreading in the hospital. And I think everyone is scared to like pan test all of the healthcare workers because they think that everyone is going to be out sick. So we don't want to do it. So rather, they're making us all go in, and probably we're the ones giving it to the patients at this point and to each other as healthcare workers. So I think I would have been way more aggressive with the development of the test, administering, universally testing everyone, and isolating and contact tracing very early on.
Mm-hmm. Would you have restricted travel?
That's that's tricky, but I think that it. Let me see. Yes, I would have. Yeah, I think that initially a big part of the hesitation was that, I mean, who do you restrict travel to? Because people are going to want to come back home, right? And now it's a year out. So for how long are you going to restrict travel? Like those are some of the big issues. I think restricting travel doesn't necessarily mean I wouldn't have let anyone into the country, but we should have had more rigorous testing of people coming into the country, which by the way wasn't developed till like what, about a month ago, that we actually have an official policy that people have to be tested for COVID before flying into the US.
Yeah, that's not even in place right now. I had just I knew somebody who just flew in and it's like,
yeah, and we're a year into the pandemic and that's still not a thing. And many other countries implemented that very early on. Many other airlines implemented that very early on. You don't get on a plane until you test negative. But we haven't done that yet. So I think I wouldn't have said, I wouldn't have restricted in the sense that no one can come in, no one can go out, but everyone would have to be tested before coming in and out.
Mm-hmm. Okay. I don't know. Everyone's so mad at politicians, either for doing too much or not doing enough. And it's like, how can you expect anybody to, what do you do? Restrict everybody's freedoms? Like you said, we are a country that, we talk about freedom all the time. And you just talk about rules, making new rules, people get very upset.
Mm-hmm.
And understandably so, but that's just kind of the history of our country. But
yeah, and I get some of it. I totally understand. I don't think anyone should be a blind follower to anyone. I'm totally, I'm a protagonist of that. But I do think, I had a conversation with one of my attendings once, and she was 65, about to retire. And she told me that, she was like, Abeer, there's been such a huge shift in how scientists and physicians are viewed in this country. She's like, we were rock scientists when I became a doctor, when you would talk science to people, there was so much respect, the scientific process and of the, of people's education and the level of training that they've had. And I think that skepticism is healthy and good, but I do think that it got to a point where everyone thinks they're the specialist and everyone thinks that their opinion is just as valuable as anyone else's, when it's a factual fact that no, not everyone's opinion is equal. The same way my opinion my opinion when it comes to politics or economics or whatever is not as valid as an economist or a politician. Mm-hmm. It's in the same way someone else's opinion who's not in the medical field or who is not a scientist, it shouldn't matter as much. So yeah, she did mention that to me, and it's definitely something that I've seen time and again, like, oh, and I don't know if you see it as much, but hey, I Googled this and like, I know what this is. I know what you're supposed to be done. Why aren't you doing this and that for me as opposed to what you're doing right now? And some people are more receptive to, I understand where you're coming from, but here's my rationale for what I'm doing. And some people are like, nope, you don't know what you're doing. I know better than you do just because I Googled it. So yeah, I feel like we're at the age of misinformation for sure. It's just there's so much information everywhere, but there isn't as much knowledge as there needs to be. It's just like people have this overflow of stuff that they can look up and find, but there isn't knowledge pertaining to these topics, and it's dangerous.
Yeah, it's almost like there's counter knowledge. There's, for every issue, there's 5 people who think they're right, and mm-hmm. Some people just want to be contrarians and say, well, this is why vaccines are bad, and or this is why this procedure doesn't work, and you have a specialist who's been doing a certain procedure for years, and it's like, wow. There's not
Yeah.
as much respect for someone's expertise, I think, because there is so much. I mean, you can Google anything, like you said, and
Yeah.
it all sounds good on the internet.
Yeah. And again, I don't think, that like the alternative is not like, I don't want people to think that, oh, like when the doctor had this like kind of paternalistic relationship with their patient, I'm not a fan of that either. I like when I have a conversation with my patient and, they tell me what they think and then we come up to a conclusion together.
Yeah.
But at the same time, there should be like, yes, I'm listening to everything you're telling me and I understand all of your concerns, but here's where my training and my knowledge comes into play, and let's come up with a plan together. But that's not where we're at. I feel like we're more at a place of, nope, I know better because I Googled it. So yeah.
Yeah, yeah. Actually, one of the craziest things that I've heard is they'll talk about people's experiences, healthcare professionals' experience who work in the emergency department, or whatever, and they'll literally have patients who are dying from complications of COVID, and these patients will be denying it, saying that you falsified my test results. There's no way I could have COVID, and that to me is very sad
Yeah.
because I don't know. I've never met a doctor or a physician, anyone who's wanted to. It's unbelievable. I've never met
Yeah.
a doctor that I felt like had ill intent.
Yeah, it's like I don't understand what people think a doctor's motivation might be out of this, like unless they think that we're also part of the conspiracy somehow. I don't know. Like
How
what
much
would
is
be
Bill Gates
my
paying you?
huh?
How much is Bill Gates paying you?
Well, as ID physicians are well known to be amongst some of the lowest paid subspecialists, so thankfully I can proudly hold that. It's kind of, obviously, it's, again, I know that it doesn't come from a vacuum. There's a reason people mistrust us and the CDC, and there is a reason behind all of this, and I understand it, but I think it's sad that there isn't any place for educated conversation to try and get people back into trusting at least the medical professionals. I don't care about any governmental agencies or anything, but at least going back to trusting the medical professionals.
Mhm. So there's just a couple more things I
Yeah.
wanted to talk to you about. I know I'm taking a lot of your time here.
Oh, that's okay.
Why can we talk about some of the multi-organ symptoms of COVID? Like why we see, why do we see so many different body systems and organs affected?
Yeah, so I mean, what we're seeing with COVID is that, I mean, the initial effect is that it does have a tropism, or as in, which means that it likes to bind to lung cells more than anything. But it does cause this overall inflammatory cascade all over the body. And that's what causes a lot of the later complications that we see with COVID-19. Is that other than the fact that people may have lung damage that will last them a lifetime, they will end up with fibrotic lungs, which means that they're less flexible. The lung is not able to exchange air as efficiently, but this overall inflammatory process increases their risk of developing blood clots, increases the risk of other organs being involved, as you said. So it's really this overall overwhelming inflammatory cascade that follows COVID-19 that explains the multi-organ involvement.
And I mean, and maybe you don't know this, maybe nobody knows this, but why is that? Why is it so different from the flu in that respect?
Um, the thing is, I was one of the people who initially kind of drew a little bit of a comparison between the flu and COVID, just because, the flu is something we're all familiar with and it has been around for a long time. So it made it easier to kind of understand what's going on with COVID. But I think that it's hard to compare both because just because, I mean, the way that they affect the body is similar in some ways in that they're respiratory viruses. They can cause lung damage and respiratory issues. I mean, the flu also has some long-term effects. It can affect the nerves. It can result in pretty serious consequences. But COVID, it seems like the main thing that is different about it, as we were saying, is that it does cause this overall inflammatory cascade. I don't know if if it mostly is related to its the spike protein, which is what we're using in the vaccine to produce immunity to COVID-19. But it could be that the body's response to this particular protein on the surface of the virus is what's causing this cascade of inflammation that is just more intense than what we see with other viruses. But yeah, I'm not entirely sure. I wouldn't be able to do like a head-to-head comparison as to why the response to one is different from another. But I do know that the inflammation produced by COVID in our body is way more intense and can have these long-lasting consequences.
So the long-lasting consequences, that's also, they call them the COVID long haulers. And I know a couple people who have been infected, and even after, they're back to work, they still talk about this fatigue that just comes on. Even, sometimes it's kind of sporadic, but they just, they're overly fatigued. Why these lasting effects?
I don't know. I don't know if we have an answer for that yet. I know for some people, depending on their level of immunity. So some of our transplant patients, that's one of the main reasons they continue to have the infection and its effects for a much longer time than other people with normal immunity. So that's one answer. It could be just someone's individual immune response to the virus that makes them more susceptible to have long-term consequences. For some people, it's because it's caused some lung damage, and that fibrosis or that change in the lung structure is irreversible. So they're stuck with these respiratory symptoms for a lifetime. For some other people, it's because we know that it can cause these neurological effects, right? That loss of smell and fatigue that comes with it. And I don't know if some of these changes are more permanent or more longer lasting, and that's why we're seeing them last longer. But yeah, I know that there's a lot of interest in the long hauler population now, and we're trying to understand why some people over others are developing these long-lasting symptoms, even though maybe their initial illness was very mild. I mean, some of these people who have fatigue, they had a very mild illness. They didn't have to be admitted to the hospital. They didn't need oxygen, but they've had fatigue ever since they've been infected. So yeah, I don't think we understand yet why that happens with COVID.
Mm-hmm. And then here's really the most important question that everyone who's very skeptic asks: if the mortality rate of COVID is so low, why should I care? Like, why not just get it and get it over with? Why can't I just, why do I have to close my business? Why do I have to socially distance? What's the real risk of COVID-19?
Yeah. Well, I mean, the risk is, we do know that the risk of severe disease in younger, healthy individuals is low. So we do know that a younger, healthy individual is less likely to develop severe disease and be admitted into the hospital and, be on a vent. But we also don't know which individuals who are younger. And that's part of the reason, let's say I got the vaccine, because I'm generally healthy as far as I know. I'm 30 years old. So as far as I know, I wouldn't be, high risk for severe disease. But what if I was one of those rare people that I did see in my practice who are younger and healthy as far as we know and did develop severe disease? What people don't see is that mortality or death is not the only bad outcome out of an illness or an infection. There is morbidity that's associated, as in, if you do develop this long-term fatigue or this long-term loss of concentration or, this long-term lung dysfunction, how is that going to affect your life for the rest of your life, your productivity as an individual? What's the cost of that? And other than that, thinking of those who are around you, because unless you are living in isolation of everyone else and you are the only person you're thinking of, you are going to affect or infect someone else if you do get infected. So I I may get infected. I may be completely asymptomatic and socializing with a grandparent or a parent or someone who has a pre-existing condition and putting their life at risk. So, I mean, you're doing it for them too, for these people that you care about who are in your immediate environment. And overall, you know, we're all just we're sick of this, right? We all want to go back to normal life, and that's not going to happen until a good percentage of us, which is, you know, that magic number, which is 70 to 80% are immune, because those immune majority are the ones who are going to protect the rest of the population, even if they don't get vaccinated, even if they're high risk. We do want to get to that threshold so we can just go back to life as we knew it, because none of us are enjoying life the way it is right now. There are some good things that came out of it, but there are some very bad things. I mean, social isolation, suicide rates are up, domestic abuse is up. There are a lot of things that, you know, that are a negative out of this quarantine that we all want to get rid of. And I think, you know, even as a young, healthy individual, you should be thinking of your community, even the smaller community. You don't have to think of the world. Just think of your smaller community and what good you're doing in getting vaccinated and just being part of healthily creating a herd immunity. You know, like, this is the rational way of producing herd immunity. So just doing your part is another reason. And yeah, going back to normal life. Just do it for selfish reasons. Just do it because you want to go back and, you know, and watch a baseball game or a football game or whatever. Just go out and go to a concert. Just do it for selfish reasons. So it doesn't have to be something altruistic, like I want to save the world. Just do it for, you know, for wanting to go back to normal life, I think.
Yeah. That's definitely part of the reason I got my vaccine. I also, my wife works for an organization, and they did a program where it was a Christmas program. So they had Santa Claus, some guy dressed up as Santa Claus, and he was in like a snow globe. So there was a barrier, and the kids got to come up and wave to him and say hi and everything. And, you know, they collected letters, and the staff of the organization read the letters, and they were all asking Santa for a vaccine and to go back to school. And it was like, it was heartbreaking. It almost brought me to tears. Like, these poor kids, they just want to go to school to see their friends and go play with their friends. And then at work too, especially with seeing more healthcare workers with it, you know, on a specialty unit, they bring in different staff, and these staff are all well trained, but, you know, they don't have the years of experience working with this, you know, whatever equipment that we have to use and dealing with certain situations. So you can see how it would create unsafe conditions, or if, you know, a surgeon, you know, someone who typically works in traumas, you know, patients who have car accidents, if that surgeon has COVID, you know, they can't do their job and save people's lives. And really, that's what really showed me the impact. And then California's running out of oxygen, like.
And that's what we saw in New York at the beginning of the pandemic too, right? And it's crazy how desensitized we got to all of this stuff. And I think, you know, part of it is, you know, it's harder for me and you to get desensitized, because even if you're not working in a COVID unit, you're seeing it all over the hospital and your coworkers and everything. And you're seeing the fatigue that comes with it too. But for someone who's outside the hospital, who's not seeing these tragic or not hearing these tragic stories every day, it's easy to just be like, you know, we're over it at this point, where it was bad at the beginning, we're over it, which is not entirely true. And now we have this amazing fix, which is a very efficient vaccine, which is safe, has been tested and is safe, and it's being offered hopefully soon to the general public, and people are still, you know, fighting it. And it's crazy to me, because this has affected all of our lives. And I don't think there's any person who hasn't been affected some way by COVID and the lockdowns and the, you know, the quarantining. I'm sure everyone has been affected in some way. And, you know, there is a fix out there right now. And, you know, and remember, I mean, this is something I also like to remind people, we don't have a cure for this infection. We have some medication that may improve mortality in some very specific patient populations, but we don't have a cure. We don't have a treatment. Once you're in the hospital, there are very limited options of what we can do for you. So that's something that people need to keep in mind. It's not like, oh, I'll get infected, go to the hospital, they'll fix it. we don't really have a good answer for this infection. So prevention is the answer. And, the vaccine is how it's done. But yeah, we have long ways to go to kind of convince people of that, I feel like.
Yeah, I mean, Donald Trump did all right. He's not, unfortunately. I mean, I'm happy that he's okay, but the man is not the picture of health. You see a lot of
Was
photos.
a part of you hoping that he would get seriously, not really like not die, but get a little sicker so people would freak out a little bit more? I mean, a part of me was kind of hoping that something a little bit more serious would happen, just so like people would be like, oh, okay, yeah, if he got sick and he was a naysayer, that maybe now I'll take it a little bit more seriously. But yeah, that didn't happen, unfortunately.
I was looking for like maybe the children's movie where the Grinch, he has a change of heart. He comes down with the illness and he's like, oh wow, this, and he has a rough go of it. I mean, and you could definitely tell. I mean, one, I'm sure he got fantastic healthcare that most people, like you said, underprivileged people don't get access to.
Yeah.
But two, there was when he walked back to the White House and he's standing there waving, you can tell that he's out of breath from walking.
He was huffing and puffing. Yeah. It was very obvious at that time.
So, I mean, I didn't wish him ill, but I was like, oh well, maybe he'll have a change of heart.
Yeah.
Maybe he'll change his tune, take it a little bit more seriously. But I guess not. But that's old news now. So
yeah.
One thing. So with the vaccine, they're talking about speeding up distribution by just doing one dose. What do you know about that?
No, so there was a consideration at the beginning. They were saying, if we have a limited number of doses, then maybe we should just do one dose. But we don't have sufficient data to do that because the trials were done based on 2 doses, and the booster dose or the second dose, was the one that after which we saw the 95% protection. So I don't think anyone's going to do that in the US, at least. I know that there have been some thoughts in maybe third world countries or underdeveloped countries, if there's going to be a limited amount of vaccine, should we just be giving one dose, or if there are issues with follow-up, should we only give one dose? But no policies have been made around that yet, and definitely not in the US. That's not going to happen because we don't have good data for that yet.
Okay.
Yeah.
And then just the last thing for me, am I right in believing that you do some sort of community outreach?
Yeah. So, I mean, the specific one that I'm involved in now is trying to get some of our hesitant populations to get vaccinated because now we're in what we call phase 1B, which is the high risk individuals and frontline workers other than healthcare workers are going to get vaccinated. We're starting to vaccinate them. But after that, we're going to start moving into even more portions of society. And we're seeing that there's still a lot of hesitancy from specific populations. So we're trying to do our best to get to those populations, get the reasons for their hesitancy, and try to convince them to get the vaccine, because unfortunately the hesitant populations are the ones who are having the worst outcomes when they do come into the hospital with COVID. So it's actually an effort, in concert with our public health department here. And so far, but we're trying to identify people who are trusted by these communities, their pastors, their chaplains, their if they have any group organizations, so Rotary clubs, stuff like that, and trying to identify individuals who they would trust if they heard from that I got the vaccine and it's safe. And again, we're trying to look for healthcare workers and providers who are also from those communities, who can talk to those people and be trusted by those communities. And so far, so good, I think. We'll see once we get to, vaccinating the general public, how much of an uptake will we have. I'm really hoping it goes well because, I'm just done with it. I know a lot of my healthcare worker friends, like that was the thing when we were like, oh, you're getting the vaccine. Yep. I'm just done with it. Like I need this to end. So I really hope it goes well.
Well, so that's all for me. Is there anything that you'd want to put out there or anything you want to talk about?
I don't think so. COVID has been kind of the majority of what I've been doing with ID for a few months now. But other than that, I think I'm kind of I'm grateful for the position that I'm in right now, and for the training that I have, because I feel like it put me in a very nice. I shouldn't say nice, in a privileged situation where I can hopefully help myself, my immediate relatives, and hopefully help the community that I'm in to get over this. And yeah, I think I couldn't have timed being an infectious disease person better. Yeah. Other than it just being fun, and I've always liked it. It was a perfect timing to be doing it. So yeah, that's it.
All righty. Well, doctor, I appreciate your time. I've really enjoyed talking with you. I've certainly learned a lot. I hope everyone else enjoyed it too.
Same. Thanks for having me.
Thank you so much.